Good afternoon and welcome to the Center for Vaccine Preventable Diseases seminar series. My name is Shaza Fadl and I'm an assistant professor in the Clinical Public Health Division at the Dalla School of Public Health and work at the Center for Vaccine Preventable Diseases. Throughout this year, our series will feature researchers whose works align with the CVPD's themes. Those are vaccine hesitancy, value and impact of vaccines, immunization ethics and governance, as well as immunity and community protection. During today's session, Dr. Deshayne Fell will be presenting on immunization during pregnancy, where have we been, where are we now, and where are we going? But first, let's start with the Indigenous land acknowledgements. I'd like to acknowledge the traditional territories of the Mississauga of the New Credit, First Nation, Anishinaabe, Wendat, Huron, and Haudenosaunee Indigenous people on which the Dalla School of Public Health now stands. The territory was the subject of the Dish with One Spoon Wampum Belt Covenant, an agreement between the Iroquois Confederacy and Confederacy of the Ojibwe and allied nations to peaceably share and care for the resources around the Great Lakes. We would also like to pay our respects to all our ancestors and to our present elders. Some housekeeping notes. Dr. Fell's presentation will be followed by a Q&A session. Please direct any questions you'd like to be answered by Dr. Fell in the chat box. If you would like to read your question out loud during the Q&A section, if you could indicate that as well in the chat box, that would help us with the flow of the Q&A. You can also direct any questions after the webinar, if it's not been addressed, to an email, which will be posted in the chat, to cvpd.dlsph@utoronto.ca. So I'd like to introduce our presenter, and it was a pleasure to have Dr. Fell here. Dr. Deshane Fell is an associate professor in the School of Epidemiology and Public Health at the University of Ottawa, a scientist in the Children's Hospital of Eastern Ontario Research Institute, and an adjunct scientist at ICES. She earned her bachelor's in physical therapy from U of T and her master's and PhD in epidemiology from Dalhousie and McGill University, respectively. Dr. Fell is a perinatal researcher whose works extensively with the Provincial Birth Registry, Westbourne, Ontario, and with health administrative data at ICES. Since the 2009 H1N1 influenza pandemic, her primary research focus has been on infection and immunization during pregnancy, and she has been a member of 2 WHO working groups related to immunization during pregnancy. So thank you for joining us, Dr. Fell, and I'll hand it over to you.
All right, thanks very much for the introduction. Okay, can you see my slides okay, Shaza?
Yes.
Okay, great. Thanks very much. So thank you for inviting me to present here today. It's really a pleasure to see some familiar names online as well. I don't have any conflicts of interest to declare, and these are my disclosures and disclaimers. So before I get started, I thought it would just be interesting to show you kind of how busy the research space of maternal immunization has been over the past 30 years, but particularly since the 2009 H1N1 pandemic, when I think that was really quite a pivotal moment, and things really started to change quite a bit after the last pandemic. And of course, here we are today in the current COVID-19 pandemic, and my guess is that this trajectory will continue to rise just as steeply or potentially even more so, given everything that's going on. So in the time I have with you today, I'm going to quickly race through a lot of material. First, just starting with a little bit about the rationale and recommendations for immunization and pregnancy. And then I'll spend quite a bit of time talking about the evidence that we have already on safety and effectiveness for the vaccines that are existing and that we already routinely recommend for use in pregnant individuals. And then I'll speak briefly about some new vaccines that are under very active research and development for future implementation, specifically in the obstetrical population. And then, of course, I can't do a talk on vaccination these days without mentioning COVID-19, so I will come to that at the very end. So first, just a bit of background. As I'm sure many of you know, we often consider pregnant individuals to be a higher risk group when we think about infection, both from the perspective of potentially being more susceptible to acquiring certain types of infection, but perhaps more commonly due to an increased severity of clinical disease if they do become infected. So we see this, for instance, with influenza, which is something that we talk about a lot when we talk about pregnant individuals, and similarly with SARS-CoV-2 infection and pregnancy, and I'll speak about this later in the presentation. And the reason for this increased severity of clinical disease, we think, is due to, not least due to things like the immunological changes, physiological changes, and anatomical changes that happen in the course of a relatively short period of time with pregnancy, and particularly become pronounced with advancing gestational age. So we often see more severe illness later in the pregnancy. Of course, we're always concerned about infection and pregnancy from the perspective of the developing fetus as well. And we know that maternal infection, broadly speaking, is one risk factor for several adverse birth outcomes, including things like a spontaneous abortion or preterm birth in some cases. And of course, there are some pathogens that cause very specific and sometimes catastrophic anomalies and outcomes in the fetus, such as Zika. And then finally, just to think about the newborn, infection also extols a disproportionately high burden of morbidity and mortality among newborns. So among all under 5 deaths globally, about 45% of them occur in the first 28 days of life, which is the neonatal period, and about a quarter of those are due to infection-related causes. And so this is really an important issue, and I think one that has led to a lot of the increase in investment in research on immunization in pregnancy as a potential to reduce the burden of infection in young infants, and particularly in the neonatal period. So I'll speak more about that as I go through. So the reason we immunize pregnant women first is obviously for direct protection to pregnant women themselves if they haven't received a vaccine or have waning immunity, or maybe haven't received a complete series of a vaccine. We know it can also reduce transmission from mother to the fetus and to the newborn. And then the last reason is that we now have a lot of evidence about the robust transfer of maternal IgG antibodies across the placenta, which can lead to passive immunity in neonates that can last for several months, depending on the type of vaccine. This is a figure from a recent paper published by Tobias Coleman, just kind of showing how in the first couple of months, particularly in settings like Canada, where we don't start any immunization of infants until about 2 months of age, there's this susceptible time window when infants really have little to no immunity. And so in vaccinating in pregnancy, we boost the maternal level of antibodies, which are then transferred to the fetus, and they then have some protection in this time period. And they hypothesized in this paper that this could have both specific benefits to immunity for infants, as well as potentially even some non-specific, or what they call pathogen agnostic benefits. So on the left-hand side are the vaccines that we already routinely recommend in pregnancy, and I'll speak about those in just a moment. And then on the right are new vaccines under development, so for respiratory syncytial virus, or RSV, as well as Group B streptococcus. And then, of course, I'll speak at the end about COVID-19 vaccines that are recently developed. So we do recommend these 3 vaccines in pregnancy in many countries around the world, including Canada. And these recommendations here are primarily derived from Canada and the US. In terms of influenza, we recommend a dose in each pregnancy in any trimester. We now recommend acellular pertussis-containing vaccine in each pregnancy. This is Tdap vaccine for short, and optimally between 27 and 32 weeks of gestation. And then tetanus is also recommended in a number of countries that are still working to eliminate maternal neonatal tetanus, which isn't really a concern here in Canada anymore because our population is already highly immunized against tetanus. But I'll just mention that briefly in a moment. There's another large category of vaccines listed here in the middle that don't have an explicit recommendation for use in pregnancy, but can be used if indicated. So for instance, if a pregnant individual is traveling somewhere that a disease is endemic, or if there's an outbreak situation, then you may decide to immunize on a case-by-case basis with these vaccines. And we have some information from studies on receipt of hepatitis A and B vaccines in pregnancy, HPV, as well as meningococcal and pneumococcal. And then there's this final category of vaccines that have a contraindication for use in pregnancy because they're live virus vaccines. And this is really due to a hypothetical concern about using a live virus vaccine because of risk to the fetus. So let's talk about the evidence we have for the existing vaccines that we already routinely recommend. And I mentioned this a moment ago, tetanus vaccination in pregnancy. So we don't really have we don't really focus on this so much in Canada because we don't have neonatal tetanus, thankfully. But this has been a really important global initiative to eliminate maternal and neonatal tetanus, which largely arises around the time of childbirth due to unhygienic childbirth practices that can result in infection, and it's highly fatal for neonates. So there's been this global initiative to eliminate MNT, largely through immunization programs of both pregnant women as well as women of reproductive age, in addition to some other interventions as well. And you can see the number of neonatal tetanus deaths globally has been drastically reduced through this initiative, which aims to immunize pregnant women with at least 2 doses of a tetanus toxoid vaccine. But moving on to influenza, which is probably the area that we have by far the most research on immunization in pregnancy. This is something we've been concerned about for a very long time, influenza in pregnancy, both from the perspective of maternal health as well as health of the developing fetus. This case series you see here is from the 1919 Spanish influenza pandemic. So this is over 100 years ago. This is a case series report from JAMA that demonstrated a high maternal case fatality of about 27% in this particular case series of infected pregnant women, and even more so if the infection was complicated by pneumonia. And then similarly, looking at pregnancy loss, about a quarter of the pregnancies were lost in infected pregnant women, but particularly, sorry, this is with no pneumonia. And in the cases where there was also a pneumonia, it was about half. But more recently, even during regular seasonal influenza, we know that pregnant women have a higher risk of requiring admission to hospital for influenza or influenza-associated complications. This is a study we did in Nova Scotia quite a number of years ago now, basically showing that during the influenza season, the risk of hospitalization increases right away a little bit in the first trimester, even compared to the year before pregnancy in the same women. But really increases across trimesters. As I mentioned earlier, often we see sort of more of an excess risk in later pregnancy. And this is stratified by lower risk in the light blue and high risk women, by which I mean individuals with pre-existing conditions like asthma or diabetes or hypertension that might place them at higher risk for more serious illness. We're also concerned, of course, about impacts of influenza in pregnancy on fetal health. And this is from a systematic review that we conducted a couple of years ago as part of some WHO work that I was involved with, where we looked at comparative observational studies of influenza in pregnancy. And basically, to summarize briefly, what we found was with severe pandemic H1N1 influenza from the last pandemic, there appeared to be an increased risk both of preterm birth as well as fetal death. But we didn't really see any increased risk with mild to moderate pandemic influenza disease or during regular influenza seasons. Although I would say that the amount of research we have and the amount of high quality research that we have in this area is still somewhat limited. More recently, there have been a couple of studies trying to further elucidate some of these risks. This is a study published very recently from Norway using the nationwide birth registries that they have there and looking at risk of stillbirth following influenza-like illness. And they compared seasonal and pandemic influenza, and what they found was no association with stillbirth in regular seasonal influenza. There were 5 non-pandemic seasons included here, but they did see this excess risk during the H1N1 influenza pandemic. But interestingly, when they stratified by trimester, it was actually earlier pregnancy influenza that seemed to be associated with later risk of stillbirth as opposed to later pregnancy exposure, which is interesting. So, and just I think speaks to the importance of looking sometimes at risk of these things by trimester. This is from another recent study that was a prospective study conducted in India, Peru, and Thailand, where they, in normal non-pandemic influenza seasons, also found a higher risk of late pregnancy loss in individuals who were infected with PCR-confirmed influenza in pregnancy. So this timeline is from a recent review that was published just a couple of weeks ago, and the timeline is from the US, but it's, I think, similar here in Canada, in that we've been using influenza vaccine in pregnancy for really a long time, back at least as early as the 1960s in the US and probably a bit later here. Initially, the recommendations over a number of decades were risk-based, meaning that pregnant individuals who had pre-existing comorbidities that would place them at higher risk for more serious influenza disease were prioritized for influenza immunization, but not the general obstetrical population. And then the ACIP in the United States changed their recommendation in 2004 to a universal recommendation that all pregnant women in each pregnancy should become vaccinated against influenza, regardless of the trimester. And in Canada, it was similar. We had also a risk-based approach until 2007, so just a couple of years after the US, when we also adopted a universal strategy. And we currently have that strategy still. In terms of other countries that recommend influenza vaccination in pregnancy around the globe, you can see there are now quite a few. Back in 2006, there were only 15 of the WHO member states that had a policy that either specifically targeted pregnant individuals or included them in a broader strategy that would have included adults in that age group. And you can see by 2014, the number of countries was 84. And a lot of that change and those new policies were adopted in and around or just after the time period, again, of the 2009 H1N1 pandemic, because pregnant women were identified early on in that pandemic as having a disproportionate severe burden of disease. And so that's why I say I think it was really a pivotal moment. There are 4 RCTs of influenza vaccination in pregnancy. They were all conducted in Africa and South Asia. The first was back in 2008, so just prior to the 2009 influenza pandemic. And this was a smaller study from Bangladesh. But on the basis of the exciting results, I think, that they found in that trial, and then the impact of the 2009 pandemic, led to these other 3 trials being conducted. These were all funded by the Gates Foundation, and they all were aiming to look at influenza vaccination in pregnancy at preventing flu, not only in mothers, but also in the babies. And so this shows the efficacy results from the 4 trials. These were pooled recently in a systematic review. So you can see the individual trial results as well as the pooled overall vaccine efficacy, which for prevention of lab-confirmed flu in infants up to the age of 6 months of age was overall 41%, ranging from 30 to 63%. And the pooled VE in the pregnant individuals was 61%, again, with a bit of a range. I won't say a lot about observational studies looking at vaccine effectiveness of influenza vaccination in pregnancy, other than to say that I think over the past maybe 5 or 6 years, we're seeing more observational studies where investigators have been able to take some routinely collected sources of data and link it with lab confirmed influenza data, which is, I think, quite an improvement on some earlier studies that were simply relying on using ICD-10 codes or diagnostic codes in routinely collected data sources. So very briefly, there was a fairly recent study published from Denmark that looked over a number of years using a test negative design. So linking the countrywide lab databases with, again, their beautiful birth registry that they have in Denmark, and found VE of about 64% against PCR confirmed infection in the pregnant women themselves, and 57% in infants up to the age of 6 months. And we're actually doing a similar study in infants here in Ontario right now. There was another international test negative study that was conducted across 4 countries, including Canada. There were 2 sites, and Dr. Jeff Kwong and I were both involved in the Canadian site. Here, we were looking specifically at influenza-associated hospitalization in pregnancy. And the reason this is so important is that it's a relatively rare severe outcome, and one that the clinical trials weren't able to look at because the event rate was so low. And so here we found a VE of about 40%. And then you can see there's another pooled analysis of 4 observational studies that found VE of 72%. And this is again looking at infant lab confirmed flu. So just going back to the trials for a minute to talk about safety now, shifting over to safety. This is again a pooled analysis of the data from either the primary publication or some subsequent secondary publications of trial data, looking at 4 important birth outcomes, so fetal death, preterm birth, low birth weight, and small for gestational age. And you can see that there was no increase in any of these adverse outcomes, and most of them were null findings, basically. The only one that was statistically significant was a reduction in low birth weight, and this was primarily driven by the Nepal trial, which was published in 2017. And this trial was actually designed to have low birth weight as a primary outcome, so it was powered to look at low birth weight. And then just looking at safety in observational studies, of course, we have many more observational studies looking at safety of immunization, influenza immunization. I don't have enough time to talk about them all. These are just 3 systematic reviews. There are quite a few more. There's even a review of reviews at this point. But basically, just to give you a high-level summary, that these reviews have looked at numerous birth outcomes, including things like preterm birth, fetal death, congenital malformations, low birth weight, and so on. And basically, they all kind of converge on this finding that there's really no evidence that we have of any adverse effects of influenza immunization in pregnancy. I just wanted to say a few words about influenza vaccination in the first trimester, because it's obviously very important to look at first trimester exposure, because we recommend immunization in any trimester. And there are some outcomes, pregnancy outcomes, that really can only arise in earlier pregnancies, such as congenital anomalies and miscarriage. But it's also important, as I said earlier, to look at earlier pregnancy exposure, even in relation to later outcomes. The RCTs only recruited women late in the second trimester, so they weren't able to look at first trimester exposure at all. So we're entirely reliant on observational studies to look at first trimester exposure. But these are difficult to do. These studies are difficult to do, not only in the immunization space, but even just in general, looking at exposures in pregnancy, partly because many of our routine databases that we use to study pregnancy outcomes only capture the pregnancies that already survive, as it were, to 20 weeks of gestation. So if they're lost earlier in gestation, they often don't make it into many of our routine data systems. Also, many early pregnancy losses are unrecognized. And if they're unrecognized, then we can't observe them in our studies. And then specific to vaccination, the frequency of vaccination in the first trimester is a lot less common. Even here in Canada and the United States, where we recommend in any trimester, it's a lot less common. And some countries, such as the Scandinavian countries, only immunize or have a recommendation for influenza immunization after the first trimester. So it just makes it much more difficult to look at. Nevertheless, we do have more and more studies over time looking at early pregnancy vaccination with flu vaccine, several that were recently published looking at things like congenital anomalies, miscarriage, as well as in relation to later outcomes. And all of these didn't find any evidence that first trimester vaccination was associated with any of these poor outcomes. Although we have now many studies supporting safety of influenza immunization with respect to outcomes that occur around the time of birth, so fetal and neonatal outcomes and maternal outcomes, we don't have a lot of information on long-term safety. And this is an area that I've been spending more and more time over the past few years. So I just wanted to mention a study that we published about a year and a half ago now that was done here in Ontario, using data that we collected in the province's birth registry, Born Ontario, during the 2009 H1N1 influenza pandemic. So obviously, in order to look at long-term outcomes, we had to wait for some time for these children to get older. And then we took the birth registry data over to the ICES environment, where we linked it with numerous other health administrative databases, and sorry for all the acronyms, in order to look at outcomes up to the age of 5 years. So there were about 104,249 children that were included in this study. So this is a one-year birth cohort from the pandemic time period, and about 30% of them were exposed to the pandemic H1N1 flu vaccine while in utero. I won't go through all the methods, and sorry for all the numbers here, but you can see we looked at a number of different outcomes, including atopic disease, as well as several categories of infectious diseases, some non-immune related morbidity outcomes that are often looked at in pregnancy safety studies, and then a few non-specific outcomes, including pediatric complex chronic conditions, which is a composite, and 5-year mortality as well. And you can see basically most of our adjusted estimates were very close to the null value, very close to 1, with confidence intervals that included the null value. The exception being asthma, where we found a very small but statistically significant increased risk, and gastrointestinal infections, where we saw a statistically significant reduction. And these estimates were very robust in numerous sensitivity analyses, and we're not really sure how to interpret these from a biological perspective, but we're looking at them in other studies as well. There was a systematic review published last year looking at the evidence base, looking at long-term pediatric health outcomes following influenza immunization in pregnancy. And I helped out with this systematic review. We selected studies that had been published up to July 2019, and there were only 9 studies at that point that had looked at longer-term health outcomes in children, 6 of which focused on the pandemic H1N1 vaccines. And this is a common theme in the influenza research, that really a large number of our studies still derive from the H1N1 pandemic time period, where we had a monovalent pandemic vaccine, and we have a lot less from seasonal influenza. So I think we'll see more studies from seasonal epidemics over time, but at the moment, they're still kind of dominated by the pandemic. So in these 9 studies, again, they looked at a variety of different outcomes. There was a lot of heterogeneity in the design and quality and outcomes, so we weren't able to do a meta-analysis. And just to point out that there were 2 studies actually that found a small lower risk of upper respiratory tract infection and gastrointestinal infection associated with the pandemic vaccination specifically, which is sort of interesting. So not only our Ontario study, but a Danish study as well. Okay, in the interest of time, I'm going to move on to talking a little bit about pertussis. As you know, this is a bacterial infection that causes a wide spectrum of illness in young children, particularly in infants under the age of 1. Who have the most severe disease burden. What this plot here is showing over time between 1998 and 2018 is incidence rates in different age groups in England. And you can see that starting in 2011 and extending into 2012, they had quite a spike, an outbreak of pertussis, including several deaths of young infants. And as a result of that, and I think building on the amount of research that had been done on the success of influenza immunization in pregnancy, the UK, as well as the US, where they were also experiencing an outbreak, adopted universal recommendations for Tdap vaccination in every pregnancy, and these have been in place ever since. In Canada, we adopted a similar strategy in February of 2018. Again, ideally immunizing between 27 and 32 weeks of gestation. And this just shows globally the number of countries that now have recommendations for Tdap in pregnancy. You can see a lot of the countries basically throughout the Americas have this strategy in place, as well as Australia and New Zealand, and quite a few countries through Europe as well. The research is really dominated by the UK and the US, I think because the recommendations were put into place such a long time ago now. And what you see is very high vaccine effectiveness estimates from observational studies, particularly in the first 2 to 3 months. All of the studies are observational in this area because there haven't been any trials to look at vaccine efficacy in terms of preventing infant disease, which is really what this whole strategy is all about. It's encouraging as well. A fairly recent study from the US was able to look further out in the first year of life and found even up to 12 months of age, a VE of about 69% against lab-confirmed pertussis infection in the infants. Just a little bit about safety here as well. There's a couple of systematic reviews, although they're getting a little bit out of date now. These were published in 2017, both of them, but both reviews concluded there was no evidence at that point of any adverse pregnancy or birth outcomes associated with using Tdap in pregnancy. And I just wanted to briefly talk a little bit about some research that we've been working on for the past couple of years now on Tdap in pregnancy in Ontario. We've been conducting several cohort studies using multiple linked databases, again at ICES. And sorry again for all of the acronyms of the many databases that were linked for these studies. But essentially, we're using sort of a similar approach as we've done for flu studies in Ontario, looking at vaccination in pregnancy and then assessment of proximal outcomes, so immediate birth outcomes, as well as some later pediatric outcomes. So very briefly, we just published 2 studies in the past 2 weeks. So you can take a look at these if you're interested. This one was in CMAJ Open, led by my former grad student, Romina Fakrai. And so her study looked specifically at birth outcomes. So things like postpartum hemorrhage, chorioamnionitis, preterm birth, stillbirth, and so on. Again, a lot of numbers to look at here, but basically we didn't see any increased risk of these outcomes. A couple of them were slightly lower, so a lower risk of neonatal ICU stay, more than 24 hours, as well as a composite for neonatal morbidity. And this is one of the first studies actually that's been able to look at stillbirth in this type of a comprehensive manner and in a full population. And so I think these results are a good addition to the literature. And then similar to what we did with influenza, we also looked at 5-year health outcomes following Tdap in pregnancy in children. And again, very similarly, our results are basically null. They're close to 1, mostly with confidence intervals, including the null value. And in this study, we also included a negative control outcome to help us determine whether or not there was any residual confounding. And we didn't find any association with our negative control outcome. But what's interesting is we did still see this inverse association with GI infections in the children, which again, we're not quite sure what that means. So something I think that needs to be followed up. So a little bit about the new vaccines. I'm going to talk about RSV vaccine first. This is furthest along in its development. As you know, RSV is a really one of the most common causes of acute lower respiratory tract infection, or LRTI, in young children, and is responsible for many deaths and hospitalizations globally each year, and particularly in young infants. Becoming infected with RSV is very common. The cumulative rate of infection is estimated to be about 97% by the 2nd birthday. And clinically, this presents as bronchiolitis and pneumonia, but is also a risk factor. Severe LRTI, RSV-related LRTI, is a risk factor for subsequent wheezing as well. At the moment, we don't have any licensed RSV vaccines for any population, but what we do as far as trying to prevent RSV in young infants is we use a strategy of passive prophylaxis using a monoclonal antibody. We use palivizumab, which is approved, but only for infants at highest risk of RSV morbidity and mortality. So this includes things like infants born at preterm gestation or having a congenital heart defect or chronic lung disease. The problem with this particular strategy, aside from the fact that it's only indicated for a small subset of infants who are born each year, is that it's very expensive and requires 5 monthly injections, and it costs between $5,000 to $9,000 per infant per year. So while this works and is used in many high-income countries and probably some middle-income countries, it's really a prohibitive strategy for low and middle-income countries in resource-constrained settings where the disease burden is also highest. This snapshot from April 7th, produced by PATH, just gives you a sense of all of the research and development that's going on in this area, and it's extensive. I'm not going to speak to much of it. You can see there's a lot of monoclonal antibodies under development, which I'm not going to talk about at all. In terms of vaccines, there are vaccines under development for different targeted populations, including pediatric, maternal, and elderly. I placed little symbols here to denote the ones that are specific to maternal immunization. And I'll start by talking about this one here, which is Novavax, which PATH is showing as being discontinued at this point. So Novavax, they actually conducted a phase 3 trial, which was completed about a year and a half ago, I believe. And I think this is really a landmark trial because it's, I think, the first time that a phase 3 clinical trial was conducted in pregnant individuals for a vaccine that was developed specifically for use in pregnancy. So this was a randomized, blinded, placebo-controlled trial of 4,636 pregnant individuals, 3,051 of whom actually received the active vaccine. So this was an RSV F protein nanoparticle vaccine, and the study was done in 11 countries. And the primary endpoint was to look at efficacy against medically significant RSV LRTI up to 90 days of life in the infants. And so very briefly, these are their results, and this is their primary endpoint here. And you can see their VE was 39%. They had a very low incidence of disease in both groups, however. And so although their 95% confidence interval didn't include the null value, before the trial was done, the regulator, the FDA, required them to have first of all, to use a 97.5% confidence interval, and required that the lower bound be 30% or higher for the primary endpoint to guard against type 1 infections. So they didn't meet that predetermined criteria for licensure. And so I think, there was some talk at some point about potentially doing another trial for this product, but I'm not sure whether that will still be going ahead. And I'm just going to continue in the interest of time. These are the other products that are under assessment now for maternal immunization, and the GSK and Pfizer candidates are both currently in phase 3 trials. Again, using an RSV F protein platform. The GSK trial is aiming to enroll 20,000 pregnant individuals, and the Pfizer about 10,000 pregnant individuals. And then the NIH product is in a phase 1 study according to the PATH timeline that I just showed, but I couldn't find any other information. So we may see results from these studies over the next couple of years. GBS is the other vaccine that's under development for use specifically in pregnancy, and that's because GBS infection is quite common in pregnant individuals and is also a leading cause of sepsis, meningitis, and pneumonia in young infants. So there are 5 serotypes that account for the majority of invasive disease in young infants, and these have received the most attention for vaccine development. What we do now as far as a preventive strategy for GBS infection is, again, we don't have any licensed vaccines at the moment. In high-income countries, what we do in most or many countries is routinely screen pregnant individuals at around 35 to 37 weeks of gestation. Those who test positive for GBS infection then receive interpartum antimicrobial prophylaxis, or IAP, prior to the onset of labor. And so what you can see in this timeline from the US is you can see here were the guidelines that were implemented for this screening and IAP strategy. And these have resulted in quite a decline in early onset GBS, invasive GBS disease in infants, but later onset disease, which is shown by the dotted line, hasn't really benefited from this approach. And then finally, this approach is very difficult. It's expensive to implement in low and middle income country settings, so it's unlikely to be used in those settings. So a vaccine strategy, by contrast, has a lot of potential because it can be given earlier in the pregnancy, as opposed to screening, which only happens very close to the time of the birth itself, hopefully inducing immunity that would cover not only that early time period for when we see early onset disease, but also later onset past the first week of life. And then potentially with this strategy, we could also prevent any GBS-related stillbirth or preterm births that are occurring prior to 35 weeks, which is at the moment when our screening strategy begins. In terms of the status, there are several phase 1 and 2 trials that have already been completed over the past several years. These were all looking at a trivalent vaccine. To my knowledge, no vaccine candidates have entered a phase 3 trial yet, but I think more recently the focus has shifted to a hexavalent vaccine candidate, so that you would have broader coverage against the main serotypes that are responsible for most of the invasive disease. So I think there's now a hexavalent vaccine that is in a phase 2 trial at the moment, I think in Africa. Okay, so moving on to COVID, I know I'm almost out of time, so I will wrap this up very quickly. As with everything to do with COVID, the evidence base over the past year has been rapidly evolving. And what's interesting about pregnancy is that initially there were case reports out of China and Europe that concluded that pregnant individuals who were infected didn't seem to have more severe clinical illness compared with non-pregnant, similarly aged individuals. However, that has changed over the course of time, and we now consider pregnant individuals to be at higher risk of more severe illness. And I'm sure many of you saw the media headlines, unfortunately, over the past couple of weeks coming out of Toronto in particular, where a number of pregnant individuals were admitted to ICU and intubated because of severe illness related to COVID-19 infection. And I don't even think we saw this many or this much of a cluster of pregnant patients in ICU during H1N1, which was another time period when we were really concerned about severe disease in pregnancy. I'll just show you a little bit of the data that we have that's pretty current. This is from an International Living Systematic Review, just showing that this is comparing pregnant individuals with COVID to non-pregnant individuals with COVID, and you can see an increased risk of ICU admission, requirement for invasive ventilation and ECMO, and then looking at pregnancy outcomes, comparing infected and non-infected pregnant individuals. You also see some evidence of increased risk of some pregnancy outcomes, including things like preterm birth and stillbirth. I'm just going to go past this because I'm running out of time. I just thought I'd speak a little bit about surveillance that we're doing in Ontario of COVID-19 in pregnancy through Born Ontario, which is the province's birth registry. Last March, Born Ontario developed a detailed clinical case report form, or CRF, which is now submitted on a case-by-case basis by a number of hospitals and midwifery practice groups across the province when they have a pregnant individual who's admitted with either current COVID-19 infection or recovered earlier from infection earlier in the pregnancy. And then this is supplemented with monthly transfer of the public health notifications from the Ministry of Health's case contact management system, the CCM system. And these are both then linked in with the birth registry, which contains all pregnancy and birth records for hospital and home births in the province. So as of March 31st, so before we had this, I think probably what we're going to see is a bit of a surge in April in pregnancy. Up to the end of March, over the past year, we had 1,403 documented cases of infection in pregnant individuals. 73 were admitted to hospital for COVID-19 related reasons, and 13 were admitted to ICU. And again, that's prior to the recent increase in ICU admissions that we saw. We should have an update on that fairly soon. Of the individuals who had already given birth at over 20 weeks, most of them were live births, 99.1%, which is good. This is about a 0.9% risk of stillbirth, which is a little bit higher than our usual background incidence, but is at this point based on a small number of cases still. So we're keeping an eye on this. 11.2% of the live births were born at a preterm gestation, which is definitely higher than our background incidence, which is usually about 8%. Ontario is also contributing to national surveillance of COVID in pregnancy. And this is just a map showing the most recent numbers that we have on the number of cases over the past year. And if you're interested, you can take a look at the reports at this website, which is hosted at UBC. So turning to vaccination, I'm almost done. As we all know, pregnant individuals were excluded from the phase 3 trials of the COVID-19 vaccines. And so what we're seeing is that vaccine policy and prioritization with respect to pregnant and lactating people has been evolving over time, understandably. And many of the national immunization technical advisory groups around the world have kind of, similar to NACI here in Canada, evolved their statements from initially not recommending or saying that pregnant individuals shouldn't be offered vaccine to now a place where they may be offered and in some cases should be offered. And particularly in the last couple of weeks, we've seen many of the NITAGs and obstetrical and gynecological societies come out with statements recommending prioritization of pregnant individuals. So you can see in the UK, this was April 17th, reported by BBC News. And then on April 23rd, the US via the CDC, as well as Ontario, recommended vaccination of pregnant individuals with COVID vaccine. In terms of what we know about safety, most of the data we have come from the United States at this point, although I suspect we'll see some evidence from Israel, hopefully in the next month or two. This paper was published in the New England Journal about a week ago. You may have seen this, and it's reporting on data from the CDC's vSafe system, which is an active surveillance smartphone-based voluntary registry. And I think they've already registered over 100,000 pregnant individuals in the US who've received an mRNA vaccine. This paper specifically reported on 30,000 as well as a subset of individuals in their pregnancy registry. They showed, this is comparing over 30,000 pregnant individuals compared with about 1.6 million non-pregnant, and just looking at local and systemic reactions, which are largely similar between the two groups. The darker blue is the pregnant individuals and lighter is non-pregnant. And this is looking at stratified by type of vaccine, Pfizer versus Moderna in the lower panels, and dose 1 and dose 2. And then importantly, what they looked at among a small number at this point of completed pregnancies in their registry is they looked at incidence of several adverse outcomes, conventional outcomes that we would normally look at in these kinds of studies, and just compared with published incidence rates from the US population. And again, if you do a side-by-side, you see that the reported incidence in these individuals who've received an mRNA vaccine in pregnancy are basically comparable to what we would expect, and there's no evidence of excess risk or signal at this point. Here in Ontario, we will be doing some surveillance as well of COVID-19 vaccination and pregnancy through support from the COVID-19 Immunity Task Force by linking the province's vaccine registry, COVID vaccine registry, COVAX-On, with the province's birth registry and looking at vaccine uptake as well as pregnancy outcomes over time. Of course, we have to wait for the pregnancies to be completed before we can look at the final birth outcomes. So this work is just getting started, and these are the investigators that are involved, including several with the Center for Vaccine Preventable Diseases at U of T. And we did similar work, as I think I've already alluded to some of this work already during the H1N1 pandemic in Ontario, where we looked at uptake, immediate birth outcomes, as well as 1-year and 5-year health outcomes in the children. So I'll just say that for any of you who are interested in vaccination and pregnancy studies, a few of us wrote this paper providing some guidance on some of the methodological challenges that I think that we'll face in studies about COVID. These are really informed, the guidance is informed by lessons that we learned from influenza studies, which are challenging enough, but I think some of the challenges will be perhaps even more amplified in the context of this current pandemic. So if you're interested or doing research in this area, you can take a look at that paper. So this is my final slide. I think even before COVID, these quotes were from 2017, but basically saying that there's a lot of promise of maternal immunization for preventing, in particular for preventing infection and infection-related morbidity and mortality in young infants, especially in global health, in the context of global health. So I think we'll continue to see a lot of development in this area. And I'd just like to acknowledge a number of people who directly or indirectly helped with the content for this talk. Thank you.
Thank you, Dr. Fell. Excellent. And I can tell you right now, there's a lot of interest, and there's several questions in the chat. So I hope we might not be able to get all of them, but we'll collect them after the thing. But first, I'd just like to introduce our discussant for today. Dr. Segun Ogundele is a postdoctoral, one of the Victor Fellows is a postdoctoral fellow in the Implementation Science cluster at the Dalla Lana School of Public Health. He is one of the recipients of the Victoire Fellowships at the center. His research interest is in implementation science and immunization research, and I am sorry, he's extremely great, but I'm looking at the time, and I just want him to have more time to ask his question than his extensive knowledge with the. So if I don't mind, go ahead, and then we'll go back to answer some of the Q&A.
Thank you, Shaza. Thank you, Dr. Feld. Thank you for that fascinating, and this is a very well-timed lecture. Summarily, I have a lot of things to say, but I will just again emphasize the it's remarkable how far we have come, looking at how you eloquently put where we've been and where we are going with maternal vaccination. And in different, from this talk and in my own little research that I've done, I'm aware that vaccination protects mothers from infectious and severe disease, and the infants also benefit from maternally transferred antibodies. So, however, with the outbreak of new infections, expanding vaccination for women before, during, and after pregnancy for newborns, children, and adolescents is necessary. So I'll cut down to my question, and this is that there are concerns about the speed, accuracy, and safety of maternal vaccines. And conventionally, health practitioners are cynical about new technology, and the population readily trusts the science. Are these roles being reversed? Are women now becoming more critical and less keen to receiving vaccines before, during pregnancy? And public health, on the other hand, public health practitioners and the authorities are more excited about these new vaccines. What's your take on that, please?
Yeah, that's a great question. And I think it probably differs according to setting, according to country of the world. But I would say here in Canada, at least, I think this has changed a lot over the past 12 years. And again, I keep referring back to the H1N1 pandemic because I think a lot changed in that time period. Again, at that point in Canada and in North America, in fact, we had already been immunizing with influenza, for instance, for many years. But the uptake was quite low. But during that pandemic, because pregnant individuals were seen to be such a high risk group for severe illness, there was a lot of momentum around prioritizing them for vaccination and recommending vaccination. And we were in a similar place back then in that although it was an influenza vaccine that was built similar to our usual seasonal vaccines, it was still a new product. It was a monovalent vaccine. It was specifically for the pandemic. And in some cases, it had adjuvants used as well, particularly in Europe. And we didn't really have experience with that in pregnancy. So it was sort of a similar situation where we had these recommendations and didn't have a lot of evidence at that point. I think things have evolved a lot, especially in, as I say, higher income settings, I would say, where we now recommend numerous vaccines. Most of the vaccines that I spoke about that are under development specifically for pregnancy, so GBS and RSV, those aren't really, I wouldn't say, happening at an accelerated speed. They've been ongoing for many years. So kind of following the normal timeline in terms of a trajectory for vaccine development that we would usually think about taking, at least a decade, if not longer. So those have been in the works for a long time. They're not really moving along at an accelerated pace. And so I think there's a lot of time for people to get used to the idea of potentially having even other vaccines that we would use in pregnancy. And I guess, for the other vaccines that we recommend, like influenza and Tdap, those are older vaccines that have been used in general populations for many, many years. And so again, there wasn't really any kind of a rush. In the context of a pandemic or an outbreak like Ebola or Zika, I mean, then the argument has been made very strongly, I think, even in this pandemic, that, particularly when the infection has a disproportionate burden of illness in the pregnant individuals and or the fetus, that they shouldn't be excluded from the opportunity to benefit from a vaccine that can prevent very severe outcomes. And so I think we've seen a lot of advocacy in this pandemic that we didn't see as much of in H1N1. So I think it just speaks to how much evolution there's been in sort of thinking about and normalizing maternal immunization.
Thank you for that. I think I agree, when there's a pandemic, then there's more attention also to the vaccines. And then we have things like hesitancy, the concerns about the speed and accuracy and preparedness of the vaccine. Thank you. I'll give the floor back to Shaza.
Thank you. I hope we can get to the next one. So Monica Canyon asked, are there any suspected additional concerns for pregnant individuals or the fetus with the gap between COVID vaccine doses recommended in Canada And what about the recommendation to not be vaccinated with other vaccines between doses? And in the sense that the concern is missing a flu or Tdap, waiting for a second dose.
That's a really complex question. I haven't seen any specific guidance around the timing of doses. And of course, it's a bit complex in Canada right now because we have an extended dose that we're using, which is all about conserving our vaccine supply. I don't think that recommendation has been changed at all in the context of pregnant individuals. So I think at the moment they will qualify as everyone else does for their first dose, and with the extended time period before the second dose. The recommendation for not receiving another vaccine in close proximity, that's a really important question because, I think the rationale for having that recommendation broadly for all populations was just so that if there's any side effects or adverse events following the COVID vaccine, that it would be if you had another vaccine in close proximity, that would be difficult to know which you might be more concerned about. And so I would say that would be similar for pregnancy. But you're right that then in the process of doing that, we could be displacing our routine immunization program in pregnancy. I'm not sure there's really a simple answer there. At the moment, we're not really immunizing against flu. This isn't, usually we do our flu campaign in the fall. So I think we probably don't need to worry about influenza so much at the moment. And I guess for Tdap, I would just say it's a fairly wide interval for Tdap, and we can receive it all year round, right? So it's between 27 to 32 weeks. So I think that's a wide enough gestational window that hopefully pregnant individuals who decide to get the COVID-19 vaccine can also still get their Tdap vaccine as well.
Okay, and then I think we might be able to get the two other questions really for shorter answer ones. Are there any concerns about receiving the COVID vaccine during the first trimester or conceiving between vaccines, and so that pregnant women would then receive the second dose during the first trimester?
So again, great question. And we just don't have a lot of information about this yet. So I think the only place I've seen so far among the countries that are now recommending COVID immunization in pregnancy, the only one I've seen that says anything specific about timing in pregnancy, I think, is the UK, where I believe they're suggesting that you wait until after the first trimester, if I'm not mistaken. I haven't seen that anywhere else, but we know that often what happens in pregnancy is that often a pregnant individual doesn't even know that they're pregnant until some period of time. And so inadvertent vaccination in early pregnancy is not so uncommon. And in fact, there's a lot of studies, well, not a lot, but maybe a dozen or so studies that have been done looking at inadvertent vaccination in pregnancy with things like smallpox vaccine, HPV, hepatitis A and B. What I can say from those other vaccines that are also not recommended in pregnancy is that those studies looking at really early vaccination through inadvertent vaccination didn't identify any particular safety risk. But at this point, we don't really know for COVID-19. And as I say, I hope, there are so many individuals who've received mRNA vaccines in the US and in Israel, where they have been immunizing pregnant individuals, that I think we'll start to see more and more data over the next while, which is great.
All right. So the next question was born. You've talked a little bit about the born registry looking at birth outcomes, but I think the question was initiating pregnancy registry, similar to VSafe, and so I'll let you answer that one.
Sure. Actually, I should have mentioned that, and I'm sorry that I didn't. So yes, in addition to what we'll be doing, there's actually a number of things that will be happening in Canada, not just Ontario, to look at COVID vaccination safety in pregnancy. So in addition to what we're doing, there is a pregnancy-specific participant-reported registry as well. I can't remember if it has a name like VSafe, but it's being run out of the same center, the Reproductive Infectious Disease Center at UBC, which is the host that's kind of coordinating the national surveillance of COVID disease in pregnancy that I mentioned. So if you go to their website, if any of you are vaccinating pregnant patients, if you go to their website, there will be a link to the vaccine registry, and pregnant individuals can enroll in the study there, and then they'll receive a number of surveys throughout the time of their pregnancy as well as afterwards. So that's more of an active participant-based approach. And then the approach we're using that I spoke about with the registries and the linkages is kind of the from 10,000 feet approach of the whole population. So two very different strategies, and that's similar, that sort of different approaches like that are very complementary, and that's also being used in the US to evaluate safety. So it's important to look at it from a number of different perspectives.
Excellent. We're at time, so thank you, Dr. Fell, thank you, Dr. Ogundele. And thank you everybody who participated today. We are also, our next seminar will be with Dr. Anne Burchell on Monday, May 10th, next week, on vaccination among people living with and at risk for HIV. So we look forward to you participating in that as well. And we have an evaluation link in the chat that was posted kindly by our superstar Liz. So please take a moment to fill it out in 2 minutes. And any final remarks, Deshane? It's been a pleasure having you here, and I think and thank you for letting us record it, because it's really important information and to share it too as well.
Thank you. No, it's my pleasure.
All right. All right. Well, thank you, everybody, and good afternoon and to everyone. Have a good day.